Hello and welcome to Level 5, Unit 505. We're still looking at the Working with Service Users with Complex Needs unit. And we're now on week 3 where we're thinking about stakeholder involvement. We touched upon it a little bit last week where we were sort of focusing particularly on involvement your service users might have. And now we're going to sort of widen the vision out about what stakeholders are. Obviously, your service user is sort of the number one stakeholder, but there are definitely others to think about, and we're going to talk about that today. Those of you who've done level 3 and 4 with me, you've addressed stakeholder engagement and involvement before. But you can always, if you've got information, you can always maybe look back at some of the things that you've done, particularly in the health promotion unit. I think we looked at it quite a bit. Okay. Now the objectives of this, which is relates to the task 3 in this unit, and the objectives are to evaluate the role of stakeholders. So what is their role? How are they going to get involved in service design and review? Evaluate how feedback from all stakeholders can be collected. So what sort of methods and mechanisms can you use? What ones might be more effective than others? Okay, so think about it from that point of view. Don't just give me a list, but give me a bit of an evaluation on those. What one's good? What one's not so good? Why is it not so good? 3.3, we're going to be looking at just the potential tensions in developing services with stakeholders. So what are some of maybe the difficulties that could arise? Okay. And that you can never sort of come up with all the answers for that because your stakeholders will always surprise you with something you never thought about. But we're just going to sort of hit some of the high ideas really. And I've added some resources for wider reading for you. Okay, so let's think. There's quite a few different stakeholders in any form of healthcare. And to be honest, bringing them together or maybe reaching out to all of them can be quite a challenge, really. It's, when you're working with your service users, be you a care home or a clinic or a home care service, your service users you see pretty much day to day. So they're the people that you can reach out for quite easily and build quite good relationships with because it's literally on a day-to-day basis. But people who are sort of maybe involved with you but at arm's length or on a more professional level, that can be more difficult to build those relationships and to find a way to encourage them to get involved in your service and to give you support when you're trying to make changes. And sometimes failing to get one of these stakeholders, especially the more arm's length ones, on board can be a threat to your project. So if you're trying to make a big change in the organization, some of the people you might really want to be on board to support you is, well, obviously the management of your own organization for a start. I mean, if they're not on board with you, it's not going to work. But also people like your regulators. So those of you who are regulated by somebody like CQC, if you don't have the regulators on board, you make a huge change in the organisation, huge change in the way you deliver care, and then find out that CQC think it's wrong or a step backwards or not following the sort of requirements or the code of conduct that's been written out for you, then that can be a real problem for you. Huge amount of time wasted, but also your reputation can take a knock of that as well, really. The same if you sort of come up with a whole new way of delivery and the people who are actually funding the placements, say if you've got a lot of service users who are funded by the local authority, and you make a change and you start to deliver care in a way that they're not happy with, well, they'll probably, I mean, they can either just vote with their feet and go and get placements elsewhere, which is going to leave you with a big funding hole, or they can be not happy and put some pressure on you to change it back again or change it in another direction. So there are certain stakeholders who can be extremely influential in what you do. And this industry, the health and social care industry, is changing all the time. It's changing as new research and evidence comes out to show why doing things in different ways is effective. So it never really stands still. It's a very evolving. As new treatments come out and new ways of supporting people come out, new technology comes out to support people. We as practitioners and professionals have to sort of stay with it really and keep up to date. So if you have a good stakeholder engagement strategy in place already in your organization or in your service, then you can, if some big changes start appearing, you can turn to it and make use of it quite quickly, which is why we encourage most organizations to actually have a stakeholder strategy if they haven't already got one. You don't have to be using it every 5 minutes, but at least you've put it in place. So let's think about who are stakeholders really. Um, you might want to sit down as a group and think about this. You might want to brainstorm it in a team meeting. If you are putting together a stakeholder strategy, you might get a project team together to do it. Now, those of you who are in care homes that maybe are an organisation that has several care homes, you might want to put together a strategy across all your care homes if if it will work that way, and it often does. It's not unusual. So you might put a project team together. So you might get representatives from a few of your care homes together, and they put their strategy together. Either way, if you're just looking at your own small organization or if you're looking at the bigger organization, you have to sit down and think about who your stakeholders are. So you need to have a little team meeting where you're brainstorming the ideas of who they are. And really, to find out who they are, you need to look at all your information sources. Who are the people that you have to talk to? Who are the people that you get information from on a regular basis or have to send information to on a regular basis anyway? Who either by part of your contract or part of the agreement of your existence you have to speak to. And then you put a list of all those people together, put them all down. You just it's the real brainstorm. Get them all down, and then sort of think about what areas you might have missed. Is there anyone else who has an influence on the project? Is there anyone who, if you don't consider, they may cause a disruption from you, like neighbours, for instance? If you don't consider them as part, if you're going to make any changes in what you do, you might affect your neighbours in the community. So you'll probably put them as stakeholders in your business. Again, service users are always number one, but also people like funders, as I said, CQC, all those sorts of things. I've jotted down a list of the sort of people that come to mind quickly in a wide way. You may have add additional things, that's fine, or they may be covered by most of these. So I've got things like clinicians, so people who might attend you, like GPs, hospital doctors, if you have people going to appointments or having regular treatments, physiotherapists who might come in, dentists who might come in, those sort of people. Patients and family members, service users and family members are obviously very important and who will need to be consulted about most things. Other healthcare providers who might bring in services, like I said, you might have carers coming in, you might have incontinence nurses, you might have diabetic nurses coming in to see certain people, you might have dentists, chiropodists, those sorts of people who might come and go into your service, or they might be providing a service to the person that you're working with as well on a quite a close basis. So if you change your approach, that might affect them as well. If you're a clinic, you probably have a variety of different clinicians who come in and out, maybe do different sessions at your clinics. So if you're changing about the way the clinic's set up, you'll need to bring them on board as well. Hospitals and healthcare facilities that are not you, so move on places, respite care services, inpatients unit, because you probably know from running your own care home that sometimes your service users might need to go to the local hospital and then come home again. So you want to be some sort of seamless information going on between the two. Government agencies, the local authority who might be your funder, CQC who might be your regulator, pharmaceutical firms. You may think that's a bit odd, but actually a lot of them can be quite helpful in the area. They can also provide with funding for certain things because they like to sell their products. And if they sell their products to the GP that prescribes to you, you can actually get them involved. They often come and do training sessions for staff, which is quite useful. And you can usually find out about them by talking to the GP because they usually chase the GPs around. But they will come to care homes because they want you to harass the GP to say, look, these have been in, Welcome have been in, and they sell the same drug that you prescribed for so and so and so and so. But they do come along, and in care homes, I used to run a clinic, and those of you in clinics probably have a bit more experience. They like coming to clinics. They'll do training sessions for you for nothing. They'll do little lunches for you where they tell you, launch their drugs. You don't have to use them, but you get lots of freebies as well. Everybody likes the freebies, the mugs and the things. But sometimes, if you're a heavy user and if they're trying to invest something in an area, they might fund some things for you, smaller clinics and that. So, I've known them to fund a clinic room for people or buy a piece of equipment for them if they think it's worth their while. There's a bit of, give and take to that, obviously, but yeah, I mean, they can be useful. Insurance companies, those of you whose service users work on an insurance base, depending on which country that I'm talking to you in the NHS, we do have private insurance, but most of our service users use the NHS. But some of your countries, all medical care is provided by insurance. So obviously, if you're a care home that has several insurance providers who use you, you need to get them on board because there's a reason why they're choosing you, and you need, they can be quite important stakeholders because if you don't communicate well with them, you may lose that insurance company. So they might not sort of pick slots in your clinic or your home. Other healthcare associations, medical tech associations, people who build equipment, people who build hoists and that. Again, if they want to sell to you, they're interested to know what sort of things you're doing and changing and that. Staff, obviously, really, really important to get your staff on board, especially if you're going to make a project change that will affect the way they work. So if you don't do that, you're just causing yourself a lot of grief if you're not getting your staff on board from the beginning. Investors, again, if you're a private care home company, you might have some investors. You need to communicate with them. You need to tell them how well their money's working for them. So that's a very different response than talking to service users. So you need to sort of find out how you talk to different people in different ways. The local community, as I said, particularly your neighbours, other organisations, other care homes in the area. It's quite nice to sort of develop a good relationship with them. Not all do, but you can actually support each other against other issues. Public health organisations, health and safety, local facilities. You never know when you might need them. And again, you might come in to do health promotion stuff, which could be really, really helpful. Like helping people with obesity, helping people with smoking and things like that. And that, you might be able to get them to come and do some sessions based in your care home or in your clinic. So they're quite good to liaise with, and also they've got a very clear idea of the way the information you should be sharing, and they're pretty up to date on new research and that as well. Non-governmental organisations, well, there's all sorts really, depending on they may be called non-governmental organisations, but they're usually created as a result of something the government wants to happen. So, depending on how important they are, it depends on whether they affect you or not, and in what way, really. So that's a bit of play it by ear sort of thing, really. If they've been set up to sort of help drive a new agenda, then it's best to be on good speaking terms with them. The media, of course, we all love or hate the media. Um, Local newspapers and that. But often local newspapers are strapped for interesting things to write about. So if you have a good engagement strategy with them, you can actually use them to positively advertise some of the good things that you're doing, maybe do a feature on you, or maybe you're having an open day, or you might be having a little anniversary thing. You get a lot in my local paper, you get a lot of the care homes get a slot, when one of the service users is having their 100th birthday and things like that. So you can only really do that if you've got an engagement strategy that's developed a good relationship with the media. And that often means that if something has maybe gone wrong, if you have a reasonably good relationship with the local media, particularly, you might be able to head things off at the pass a bit if a bad article might be written about you, you might be able to get in and make it a little bit better. So it's quite important that you have quite good engagement with the local papers, but also that you remember your limits of confidentiality and things like that. And they do try to come and breach that quite often, but you need to be quite strong about that. But if you have a good relationship with them in the first place, sometimes they don't push it quite so hard. Research institutions can be really helpful. You could be used as, part of an experiment or part of a piece of research, which can sometimes bring in a little bit of extra funding for you. But also sort of shows that you're very up to date by taking part in modern research. So it's worth keeping them involved. They don't want to be interested in all the day-to-day movements of your organization, but just that you're there and what you serve and that. So they might like to get a bit of update from you every now and then just to keep an eye. Charities, again, they might support a particular illness or disability that can be really helpful. Like Age Concern in the UK is a very powerful charity that supports older people, people who are going through the aging process and the dementia process. They give them loads and loads of advice, but they also have lots of things that can help supplement the care that you provide. And as I said, they do fantastic information booklets, do lots of legal advice as well for people who maybe can't really afford, to get in a lawyer. But when someone maybe moves into a care home, they might be worried about, writing their will, leaving their will, the sort of help for their children that they leave behind. And that might worry them so much they end up making themselves iller in a way. Age Concern have got some fabulous legal support that you can put them in touch with or bring someone in to see them, and they can really help them do that well. So that's just other charities might work specially with people with heart problems, people with diabetes, people with epilepsy, all sorts of things, and they're often actively involved in new research. So it's another way that you can link in. So getting some of these charities on side can be really beneficial for your service users. However, they don't want to hear again about your everyday single movements. They just want to hear about something special, or you just might want to keep an open channel so that they can contact you if they want to come and do some research or something. They're really depending on how you want to involve them, the stakeholders. It's like how you've got to decide how much you inform them, and what part they have, what part they play in your sort of development strategy. So looking at that, with all sort of health and social care research, we tend to have what is known as the 4 Ps. That helps us sort of direct who our stakeholders are. And the 4 Ps, this was obviously particularly developed in the NHS and public health: patients, providers, policymakers, and the payers. And that sort of answers its own question, really. Who are they? Patients, these are the service users, these are the people who you deliver a service to. Providers, these are the other people who deliver services to your service user, or people that might deliver a service to you. So you might have someone coming in delivering all your PPE. You need to consult with them sometimes about issues as well, but you wouldn't consult with them as much as you would about certain things as you would about consulting the carers of your service user, or they would be about different things. Okay, but we mustn't forget them, because if you make loads of changes to the way you order things and organize them, and none of your suppliers are on board, then you've got a silly problem that you didn't need to have. So that's providers. Policymakers, as obvious as government. In this country, that's CQC, who are the known regulator. It would be the local authority who would be funding a lot of people's placements, or it could be the NHS who might be funding your clinic to existence. They're all policy makers. They all create policy. If the policy changes, you may well have to change the way you provide services. So the government created the Care Act of 2014 that we've talked about recently, and all the work you do has got to be within the requirements of that Care Act at the moment. If another policy comes along that either changes that or improves on it or just tweaks it in different ways, you need to be very aware of that and very responsive to it. And to do that, you need to have some good engagement with them so that you don't get left behind. So it's really important to speak to the policymakers and not wait until they come and dump something on you that you hadn't been prepared for. They need to be in at the beginning, really. And payors, again, whoever's paying for the service. And again, that could be your service user if they're a private client, if they're paying out of their own money, or family if they're paying out of their money, or it could be the local authority if they're paying you for a service. Doesn't really matter. But they are people, obviously, they are customers in the true sense of the word. Okay. And if you don't communicate well with them, if you don't give them information when they want it or need it, they may choose to go elsewhere with their custom. It's quite that simple, really. As we would do when we go to a shop and we can't find what we want, and the shop assistant's a bit useless and don't come and give us information. You just walk out and you go, right, I'll go somewhere else then. So why can't they do that with you? Well, they can eventually. I mean, sometimes it's a bit more complex because they may have made a contract with you and that, but in time they can take their services away. It's important to take that time and be thorough and sort of, look through all your data resources. If you are not sure who else might be involved, maybe use a bit of social media. Find out who's talking to who on social media. Find out who's talking about the things that you do and that you provide. And find out who's questioning, I want to know about this clinic. I want to know about this care home. Who's been searching for you? Because if they've been searching for you for information, then they might be stakeholders that you need to consider. So before you get started with creating a communication plan, the most important thing is to determine the needs and requirements of your stakeholders, because they don't all require the same level of information, as I was sort of hinting at earlier. Some of them will want to be very involved in the changes that you make or the developments that you make. Some of them won't want to be involved at all, but would like to know about it. And some of them sort of will straddle it halfway. They'd like to be involved in some things, but not other things. So you've got to be fairly practical and put people into the right brackets. Because if you try to involve everybody in everything, they'll just walk away from you. They'll drop away. But if you don't give some of these people any information, then you'll lose them as well. Okay, so it's just having a good think. So you've got your list, you've had a massive brainstorm. Some of them may be more relevant than others. It doesn't matter. Better to have a bigger list than a smaller one, because you could probably discard some as you go along. But it's better to have too many ideas of stakeholders. Then you do something known as a stakeholder analysis. You have a look at one of the resources I've given you. It's given you some sort of practical ways of doing things, so don't worry about that too much. But it'll provide you with a clear view of who the different stakeholders are and how much they impact it. And to work it out, sort of start with some of these questions. As I said, it's useful to have a little project group who's working on this. And you do need sort of, when you're brainstorming these things, you do need a proper session. It's quite hard to do it when people are doing their normal work. So you either put a slot for it in a team meeting, or you have a separate meeting somewhere, maybe after work, where people could actually sit down and throw these ideas around. But you do need to give people the time to do it. Think about what stakeholders have a really fundamental impact. What stakeholders were basically, if we upset them, would we really suffer? So have a think about those. What is the relevance of their relationship? Do we have a good relationship with them? And is it happy? Do we want to maintain that? Do we have a bad relationship with them? And do we really want to make it better? Do we have no relationship with them, but would we like some more of a relationship? So again, if you sort of think you've got no relationship with someone and you don't think it would affect the project, whether you had one or not, maybe they're not people you need to take forward. Who will be responsible or have decision authority on the project? Is it solely your decision as a project group? Are there another level of management that need to get involved in it? Do you need to run it by your funders first before you make the changes? Remember, if you make a change that loses your funders, bad move on you, because that's really not going to work. And also think about not just the people who buy your services, but think about the people who invest in your services. A lot of you are in private care homes, probably, where there are some people with money who invest, who put the money up to back the home. How much do you think they want to be involved? And if you're not sure, you can ask them. What do you want from them? What do you expect from them? Will they be setting standards for you? Or will they just want to give you money but don't care? It's unusual. Do you want feedback from them, or you just want them to know about something? Do you want them to be part of it? So if you're talking about senior management, you probably want them to be part of the developmental change anyway. If you're talking about your funders, they probably don't want to be, they don't usually have the time or the inclination to be involved in it, but you might want to send it to them and get their views on it before you make any decisions. So it'll help you classify your stakeholders. And the thing you're thinking about is that their relative influence and interest. Some people may be more interested in your changes in your service than others. Now, there are models for doing this. These are the two most well-known, the salience model and the interest influence matrix. The salience model is a little bit harder. You use a Venn diagram that overlaps. You have three areas, one of power, one of legitimacy, and one of urgency. Where the three areas overlap, you will get who is the definitive stakeholder, and that's like what one would say is the most important stakeholder. But as you can see, there are dependent, dangerous, dominant, discretionary, demanding. There's quite a few things to think about. We don't use that one so much in health and social care. It does get used a lot in business. Okay. But I'm going to leave that one to you. If you're interested in it, you can do some research in it. You can Google it. You'll find out a lot about the salience model. And I'm going to lean towards the one that we've, certainly used a lot in the NHS, local authorities all the time. So it's been very, very familiar, excuse me, in documentation. So if you read a bit of research, particularly around NHS stakeholders and that, we'll always use the interest influence matrix. Now, I've told you that someone's bound to use the salience, but it's not common. Interest influence is the one that I've had the most experience of and have seen in most government documents tend to use it. So that's the one I'd like you to get your head around the most. Also, it's a little bit easier to do. It's a bit clearer. Okay, so with the interest influence matrix, if you have a look at my little squares here, my chart with the squares, you can see at one side you've got a red line running up which says influence. And along the bottom, you've got a red line running along that says levels of interest, basically. And it goes from low to high on the influence scale and low to high on the interest scale. Then your chart is broken into 4 quarters. So the top quarters will follow in line with, so the top quarter to the right will be high influence and high interest. And if you, the other way around is the bottom left hand quarter will be low influence and low interest. So if you have a look, I've given you an explanation of the sort of things you should do. So if you look at the low interest, low influence quarter, the only thing that we've got in there is monitor and inform. So really, stakeholders, when you put them into that quarter, you just need to let them know about things. You may well send out a newsletter or an annual report or something like that. Or there might be something that you've agreed to sort of send them as a monitor. So you just inform them of things. We'll focus first on you sharing information. So that's an inform. If you look at the other 2 quarters that are low interest, high influence, or low influence, high interest, they're both the same, and they are known as the inform and consult. So a little bit more, not just information. We inform regularly of changes, but when we're going to make a change, we consult. Okay, might send out a consultation document. We might send out a document explaining our plan, asking for feedback. We might send out just a little survey on, we were thinking about making these changes. What do you think? So either way, we do some form of consultation. We might go and do a focus group with them. It really depends, who they are and how available they are. And if you have a look at where it says low interest but high influence, it says here, keep them satisfied, engage on a recurring schedule. So someone who's really not that interested but actually can stop your project, say like your investors, they don't want to know about your day-to-day because they just invested money. Some of them may love your care home, but some of them just see it as a money vehicle. You just have to keep them informed. So normally they tend to get, quarterly reports, or they might, as I said, the annual report might be happy for them, but you do need to get some feedback on, does anybody know how they'd like to change it? Are you satisfied, dissatisfied from this return? So engage on a recurring schedule. They usually, the consultation is usually quite simple. and usually sort of set to a schedule like quarterly or annually or biannually or something like that. With the people who are high interest but low influence, you engage with them as needed. They haven't got a lot of influence and they're not going to change anything, but they're very interested in what you do. Now, that can change. And that is why, with all of these, you don't lose contact completely. Even the people down in the low quarter, the low and low quarter, you should monitor the situation. They may not stay low interest, low influence. Something might change. Some government policy might change, and those people might suddenly become high influence, even if they're still of low interest. So you should always monitor any developments and how it affects your stakeholders, okay? And particularly, as I said, with government policy, where they might bring in different organisations to do stuff, that might have a knock-on effect to your care home or your clinic work. Okay. So engage is needed for those. So those you might actually ask them, you could even ask them to join a project group, I don't know, but you will definitely be consulting. A frequency of consultation might be a bit higher with those. But the highest one would be those of higher influence and low interest. But they also will tell you, they might say, look, we don't want you sending us consultations all the time. So I get fed up with it, really, because they've actually got low interest. The people with high interest, that might change. They might suddenly decide that they can be helpful or might want to start funding your project. And then they become even more important. So you've got to, what you've got to do is work with them and sort of think about how often do I consult? And, get some feedback from them. Consult with them on how often they want to be consulted and then put that down in a schedule. If you think it's unreasonable, just have a look at this matrix again and say, well, they've got no real influence on me, although they're very interested in the project. It might be because of their own personal gains, because they've got, like their mothers in resident in your project, or you're delivering your service to their family or something like that. That doesn't mean to say that you have to constantly give them information any more than anybody else. So you've got to find that happy medium, really. It's got to be good for your organisation and good for them. Now, the people that really matter are the people that are high influence on the side and along the bottom, high interest. You've got high influence, high interest, and they come together in the top right-hand corner. And they're ones that if their influence is very high, they could close your project down. That could be CQC, that could be your local authority funders. If they fund 80% of the beds in your care home, then they have high influence and high interest. Because if you mess up, their reputation will take a knock as well, because the local people will say, look, they're using poor suppliers, they're using poor care homes. So it really matters to them. So things like your CQC, those of you who are regulated, or whoever the regulator is in the country that you're living in, if the regulation, you've got to keep the regulators sweet. You've got to make sure you meet the standards that they expect of you. The same with your care staff. They've got to meet the codes of conduct of their professional requirements. Otherwise, that will have a knock-on effect to the regulators. If they find out that you're not, if there's been complaints about them, then the regulators will downgrade you, and they could have a very negative effect on you. So what do? We inform them regularly of things, so they get part of the regular information that maybe some of the others get. So again, your annual reports, maybe a quarterly report. They come in and do at least 1 year annual inspection anyway, so they create their own report. But it doesn't mean to say they don't like to get your annual reports. If you're making some changes, if it's a small change, you might consult with them. Again, you might send out a little survey to them. You may ask them if they'd like to send a representative to a project group if it's a bigger change. And this is where we move on to the last thing for them. It's collaborate. So with that group, you don't just make the changes, or you don't just get a little bit of feedback from them and then make your changes. You need to actually involve them in your changes. And again, the best way to do that is to have someone on the project group. Sometimes it depends whether they've got the ability to do that. They might not have the free time, but you have to agree how are they going to be involved, really. And it could be that as you get through different stages of the project, they get the sort of project review documents. So if you're making a massive change, you will be having project review documents for your change project, and they might say, well, okay, just keep me involved with the project change and just give me a time factor. But you might also say, well, actually, after every project change, I'll send you the information and then I will ring you to find out if there's something that you have real concerns about or you want to change. So just because you're offering, you have to offer to collaborate with them. Sometimes they'll turn you down because they don't have the time. But the fact is you've put in the offer. So the only thing you can do is to chase it up by saying, I'll send you the information, but you go back to make sure that they sign it off. Or you might agree a sign off process with them. Yes, we're engaged with this. Yes, we agree that you should go forward. That's what I have done with people like that, because they often don't have the time to be involved, but then they say afterwards, well, we were never really involved. So get their signatures, to say that they have signed it off. And if they haven't read it, that's sort of their problem, really, in a way. But just remember, the people in that top right hand corner are make or break for you. They are the ones that can either close you down, lose all your custom, change you, pretty much end you quite dramatically if they wanted to. So you do need to engage closely, and you do need to let them influence your actions. And you need to have a good two-way responsibility, so you can influence their actions as well. Again, so if you have a really good relationship with CQC, if you've breached something, instead of them just going on to the action, hopefully, if you've got a good enough relationship with them, they'll give you a chance to fix things before they, do their final report. Those people who don't communicate well with them, they just get the report and then everyone sees it and that's the end of it. So bear in mind that. If you're not sure about the models when you're having a look at that, you can always just WhatsApp me in the usual way if you want a bit more explanation. But again, there's a workbook that will be part of the resources that you can have an idea about how people do things like this. So it should be in that as well. So we've mentioned quite a bit that communicating is really important. Why is effective communication important? Because it will support your projects. It will promote people being involved with it and the right people being involved with it. It will help shape the decisions that you take, really, by getting feedback. You'll find out what matters to your stakeholders by having good communication, and you'll use that information to make changes. You'll also understand where the potential risks are as well. And again, that might help you to stop you doing something that you might regret later on. You'll gather insight and perspectives. The government employees might give you some idea of where government direction might be going, policy might be going, which is really, really helpful if you get in at the beginning and find out about it. Because when you hear about policy, it takes quite a long time in most governments to actually produce a white paper and actually turn it into legislation and turn it into a policy. But that doesn't mean to say if you start knowing about it early and knowing that it's looking very positive, then you can start, at least having an idea of what you might have to do to your own organisation to make a change. It helps you support the different stakeholder groups. So for patients or service users, good communication helps them understand the role of your organization, what it's doing, and why it's doing it. And it also, you can let them into the idea of some of the challenges that you face. So if you do having to change different care models, you might be able to get them on board easier if they realise that it's not financially viable to provide this, and this. There's no point sort of pretending about it, but if you dump this on people, you often find that they will fight it. Whereas if you bring them with you and you lay it all out to them and show them what the funding is, they can be a bit more helpful and a bit more tolerant about changes. Communication helps partners. It enhances your collaboration with your community partners, and that could be for working with other organisations, working with your suppliers, so they supply you smoothly with no hitches. You don't run out of PPE, things like that. But also just with your neighbours, having a good relationship with your neighbours by letting them know what's going on without breaching confidentiality, of course. That's always been a bit of a difficult one, but it also amplifies your voice within the broader system. So hopefully you could maybe speak to other organisations. Good communication with partner organisations in the locality is really important, because sometimes things happen and you have to help each other out. And if you do that, it will always get remembered well, you know. I remember a care home that in a locality that had a terrible fire. And it was great because they were a very popular care home. They had really good relationships with other homes in the area. Other homes in the areas helped, and took service users for a while things were getting back to normal. Without that support, without that good relationship, it would have been, on top of the dealing with the fire, they would have had the stress of having to deal with that. But no, when this fire happened, quite quite a lot of local organisations stepped forward and said, "What can we do to help?" They didn't have to go around looking for others, and within, if I remember, within like a day or two, everything was sorted, and people were safe and secure, and they were able to go ahead and sort of, make all their repairs, knowing that their service users were safe and well looked after. And that was really good. And that's the way it was really nice to see a community really work well like that. Again, some service users, families just because the relationship was good with a care home, they acted very quickly to take their service user home where they could for a few days while things were getting sorted out. But other care homes stepped in. I've got 2 vacancies here. I can take 2 people here. Hospital would take some. Well, they're not very good at doing that, but it's your relationship with your other care homes that can be really, really powerful. Effective communication also with the staff, really, really important. If you're involving staff in making changes or bringing in new policy, it helps them feel integrated and part of the team. It helps them feel, more importantly, part of the organisation, that they're not just there to do a job, but they're actually contributing something to the organisation. If they feel that you feel that, then they will be a lot more positive about maybe going that little extra mile, up in the quality a bit as well. It helps them understand their role better, and it helps them work towards your shared goal. So really, getting your staff on board is absolutely vital. Before you bother getting all the other stakeholders out there on board, you need to look inwards first and then outwards. Okay. So proactive communication strategies. What are the proactive ones? There's loads of engagement activities you can implement. Those of you who did the health promotion unit in the level 4 will remember this. You can do things such as workshops. You can have little events. You can have forums, just groups. You can have focus groups where you just call people in to get their views on something. You can send out surveys. You can do text messages, newsletters. So let's have a think about what we can do. First of all, assess the tools you've already got. What sort of things do you already use? You might already have a website. You might already have a Facebook or Insta page. You might already send out newsletters. So make the most of those. These are things that people are used to getting from you. So work with what you've got. Community engagement. You might collaborate with local partners, churches, schools, community groups who may be very much in your locality. Um, they they might help you with a wider communication as well. So imagine if you've got a church who's maybe actively involved, say with your care home, and you want to get some information out, you can get it out to the church, and the church will get it out to a much wider group of people in the local community as well, because obviously they have the church may be part of your newsletter group, but their newsletter group is probably even bigger than yours in that sense. So utilize media that already exists. What does local media and what social media platforms do your stakeholders follow? What do they act on? So, maybe they've all got their own Facebook pages now. Maybe they've all got their own Instagram. Certainly other care homes probably or other clinics might do. Those that are maybe NHS, they don't tend to have Insta, but they can have Facebook. They can have specialist Facebook pages and things like that. So find out what people are using already and then be present there. You could just follow or you could post little bits on it, think about what works the best. And again, if you've got anybody in your service who's got particularly good skills with social media, like they often tend to be at the younger age group, but if someone's really got some naturally good skills, but you have to make sure that they don't make any changes before a certain level of management agrees them, because somebody might say things that the organisation doesn't want to be said. So you've got to work out what a sign-off procedure is for social media. And I don't suggest that you give all staff access, to your social media to go around circulating stuff about you. It's got to be a managed process, because I've certainly had experience in one organisation I worked with where people were merrily posting stuff on Facebook on our behalf, and some of it was extremely detrimental to the organisation, and they lost their jobs over it, but because they were posting very unpleasant things. But you need to have some control about it. So you need to try and monitor. So normally, certainly in the organisations I've been, we had a sign-off process. Nothing went onto social media that had been signed off at a certain level. So they had to see the draft of it and then put it on. Or sometimes you might have an IT department where you've got one person who's actually allowed to post on social media. It depends on your organisation. It tends to work quite well with that. And then the staff can bring it to them, but they'll get it checked over if not. Patient participation groups. Some of you may already have experience of that. You may have a residents group who feedback on issues in the house, but it's a good way of testing out things. If you're making a big change to your newsletter, you can test it out in your patient participation group to ensure that it's still relevant and it still works, and the language you've used is good. It's accessible for people with different issues. Quite good maybe for people. If you're working with people with disabilities, you need to do certain things. You need to have the right colours, you need to have the right size fonts and that. There's quite a lot that you can find out about that. It's quite easy to access. But you need to think about all those sorts of things. A collaborative approach, you need to share your expertise. Again, if you're an organisation that's got 5 or 6 care homes, you might find you put a communication team together across the both, people with lots of expertise. You might already actually have a publicity team that does a lot of this work, and then generally if you do, Your social media would go through them as well because they've got the special skill. But if you don't have, you can actually have a project team across the organisation with people with skills and interest in the subject doing it. And that way you can distribute the workload fairly well. You also need to set expectations. So when you're communicating, when you go back to the sort of low influence, high interest, with the people that you're just communicating with, you need to come up with agreement about the frequency and that, and make it so it's not onerous to you, that that you don't have the time to do any other bits of work. Remember, so I do remember people get too enthusiastic about creating newsletters and then set a frequency where you're going out to someone who probably only wants to hear from you a couple of times a year, and you send them a newsletter every week, and in the end they all go in the bin, or they get their emails, they just get cleared. So it's got to be practical and it's got to be sustainable. If it's people you only speak to once a year, you don't send them weekly information. If it's someone you see once a year, send them an annual report, or a couple of times a year, send them something. But keep it short and sweet. If it's someone who's got very, very high interest, very high influence, yes, you'll send them a lot more. Okay. And I think only you can work that out between you as your little project group, your communication group, thinking about, who they are. And if so, if you're not sure, then, bring in senior management to sort of have the final say. Okay, so that's the process. What are some of the tensions in developing services, particularly bringing in a variety of different people, maybe not all professional? First of all, if you're involving your service user, you need to think about their health status, their wellness to be part of the group. If someone's got a mental health problem and they're in a particularly acute episode, maybe they might feel that they're not able to contribute, or they might not want to be part of it that session, and then maybe you pick up with them when they're feeling better. Or if someone, if you're in a care home where a lot of people have dementia, you want to involve them, but there's no point giving them sort of highfalutin language to deal with because maybe their memory is not so good. So you might have to create their consultation part to make sure that it's broken up into little bits, little chunks. Focusing on just certain things, and then maybe another session another day. Yes, that will be quite hard work, but it's the way you have to deal with people with dementia, so you can't overload them really. The other tension could be age-related assumptions, which is really difficult one way or another. One of the interesting things about age-related assumptions is the thing about using technology. There can be an assumption that anybody over 60 can't use technology properly, doesn't use their mobile phone. I cannot live without mine. So just, don't assume that just because somebody like me who is over 60 can't do quite a lot of very interesting things with their phone, as well as, send my pictures, do my this, do my that, make my stories, do things. But on the other hand, you can't put yourself in the position where you assume that they can do everything that you can as well. So it's to avoid the age-related assumptions when you've maybe got your group together. It's just you either speak to people who know the people really well to find out a little bit about them, or you send them out a little survey about themselves, like what do you like doing, what do you like using, do you use Insta, do you use Snapchat, do you use this, do you use TikTok, do you use YouTube? So it's just to find out, why don't you, if you don't use this, why don't you use it? No, it's too difficult. You don't like it because it's boring, all those sorts of things. So try to resolve some of your assumptions before you start communicating with them. And that would be part of when you're gathering information, really. So here's my Here's my service user group. I think that's really important, the service user group. If you're dealing with professional stakeholders, you've got pretty much a good idea about what you can send out to them, because they um, as professionals, they should have some of the skills really. But with the service user group and with the family group, the family carers, you need to find out a little bit more very often. The other issue is people might not have self-confidence, so you ask them to join a project group. It might be, and this could be for staff as well. They might be a bit shy in speaking up. They might not want to have to speak in front of other people. You might want to find processes for that. They might, English might not be their first language. That might be difficult. They might feel embarrassed about that, or they might just struggle with some of the information you're delivering. So if you knew that, then you might have to produce that information in a couple of different ways, or even translate it for someone who's on a group. Relatives, I've got here, relatives sometimes impede involvement, and this is true, especially when you're working with people with disabilities or people with age-related issues. You may have already come across that, those of you who run clinics, care homes, supported care. But sometimes people think that the person that, their mother, their brother, their sister can't do it, is too unwell to do it, and try to stop it happening, try to stop them getting involved. You've got to work with this sensibly, sensitively, and carefully, really. But if the service user wants to be involved and they are able to, then sometimes you might have to challenge the relative gently, and just say, look, we're going to give them lots of support, but they really want to do it and we want them to do it, really. A particular issue for parents of people with learning disabilities who, don't always accept that their service user can learn things, and don't always accept that their service user is no longer a child and actually wants to be involved in their life. And that's hard work for them. It's about releasing these sort of controls where they've taken care. So you have to be super sensitive, but you've also got to work with the service user and the family to let them sort of take their hands off a little bit. And that's part of the work you'd be doing day to day with them anyway. But it's something that we particularly see with young people who are, becoming more mature, young people with learning disabilities or quite profound physical disabilities. Parents find it very difficult to let go, and you just can't march in and demand that they do that, because you're going to ruin a relationship. So think about that. Capabilities being underestimated, people just assuming that because they're a service user they've got nothing to offer. That's pretty tough. Contributions being limited because of that. People saying, "Oh, you can do this, but you can't do that." We need to think about power, privilege, and discrimination as well. So if you've got professionals in the group, say like a GP might be joining the communication group, and there's a service user or a relative on it, and you have to make sure the GP doesn't try to extend their power to make things go the way they want to, or if you get worse still, if you get a consultant on it, and they're very good at intimidating service users. So think about that. Clear definitions, understanding about roles and what are they there for. Best if you create some sort of written role if they're going to join a group, a consultation group, that's not just a one-off but a sort of an ongoing one. So they have a really good understanding about, why they're there and what the extent of what they have to do is. Training for lay people. So for some of your staff who maybe want to get involved with stakeholder management, want to get involved with doing communication strategy work, a little bit of training would be really, really helpful. Bringing someone in to talk to the team about it, or if you've got a project team together, making sure they get, it might only be a half day or something, or going to a workshop or something like that. The same for the service users as well. Again, especially if service users are going onto any group where they're professionals. If you can get a little bit training for them, loads of the charities do bits of training for people to advocate for themselves. MainCap do quite a lot of stuff for people with learning disabilities, age concern again for older people, so that they can get a bit training in speaking up for themselves and other people, which is really, really valuable. Use the technical language if you're having a group where you've got lots of non-professionals on it. Using professional language, not helpful. Jargon, really not helpful. Technical languages. If you've ever sat down with someone who's an IT specialist and they've had a conversation and you've sat across the table having a cup of tea with them, you'll know what I mean, really. That sort of thing is not helpful to bring people in, and so that will hold back your development. Also, the speed at which discussions take place. For some people, it needs to be kept at a fairly good pace. We don't want it to go so slow that nothing happens. But also, the discussion can't be so fast that either people can't keep up, get lost, miss out, and or don't know what they're agreeing to. So the best thing to do with that is you can always reflect back to people as you go along, check in with them, and if you see that people are struggling, maybe slow the conversation down a bit. Okay. Other classic organisational barriers, and I'm sure you've probably all experienced one of these, is competing demands. I'd like to join that communication project group, but I've got a lot of care plans to write, and I've got to write them all by Friday, and so I have to miss my group. If there's a shortage of staff, asking people to again take on interest groups is asking a lot of them, because they're probably already doing extra work, just doing day-to-day cover. Is it the right time to put a project group together? If the staff turnover is high, that's frustrating. That would slow your development down, because you might have someone who's really good, who's joined your project group, but then they leave, and then you have to find someone else, and then you've got to catch them up. So it's slow. Lack of staff buy-in. If the staff don't think there's any point to what you're doing, most of them won't volunteer to join, and then they won't carry it out once you've made the decisions anyway, because they don't believe it's a good idea in the first place. So you've got to get the staff on board with either your project group or with what you come out with. Before you set it into train, you really need to bring the staff on and get their feedback on it before you go forward. Clinician fears about challenges to a medical model. Well, that'll always be there. We've talked a lot about the medical model and the way it works over different units. And there is always an issue where you're doing something where you might be advocating for more service users taking more responsibility, or day-to-day staff taking more responsibility for changes. And if the medics feel that the medical model is being challenged, some of them are great, but some of them will find that very unsettling, very difficult, and they might try and sabotage the work that you're doing. And generally, staff workload and time constraints. People do need to go home at a certain time, and they do need to have some of their own time at home as well. So you can't expect people to sort of give up all their free time and that to do all your project groups. So you've got to be realistic, and you've got to sort of organise it quite well. Okay, so that's pretty much it for this week. Have a look at your week 3 resources that I've sent for you. There are 2 research articles to help you address the criteria a bit further, so have a little look at those. And there's also a really good workbook with further information on how to gather people's views. You can use the workbook any way you want. You can just pick up ideas from it, or you can work through it if you want, if you think it's helpful. Okay, so that's the last of the stuff we'll be doing on the criteria. So week 4 is I'm just going to go through the assignment. Okay, so I'll see you in week 4.